So clearance is abbreviated as CL, and it's defined as the volume of plasma from which drug is removed per unit of time. And it's a complicated concept, but stay with me on this. Its units are volume over time. So for example, you get a value of something like 500 mils per minute or 2 liters per hour or something like that. And it's essentially a measure of how efficiently the body is getting rid of the drug. The higher the value, the more efficiently the body, or particularly that organ, is able to clear the drug. And usually in clinical practice, it's independent of the drug concentration. But in clinical trials, it's important that we look at whether in fact clearance is concentration dependent or not. So why is clearance important? Well, in clinical trials, it's one of the factors that determines the half-life of the drug. More on that shortly. And it determines the overall exposure of the drug. So it can contribute towards adverse effects by increasing the exposure if in fact the clearance of the drug is slow. In clinical practice is again one of the factors that determines half-life, which is important, and also determines the maintenance dose of drugs when we're using it for chronic ongoing dosing. And how the drug is cleared then determines dosing modifications in cases of things such as renal or hepatic impairment. In our clinical trials, this is less relevant because all our subjects have excellent renal and hepatic function. So what are the organs for clearance? Well, they're predominantly the liver and the kidney. Now, various other organs may contribute, and particularly this is important for biological drugs because they're cleared by binding to the target receptor. And the total body clearance is the sum of the individual clearances. So for example, if a drug is cleared renally at say 250 ml per minute and hepatically at 750 ml per minute, and a lung clearance is, for example, 50 mL per minute, then the total body clearance is just the sum of these. So that's 1,050 mL per minute. So let's have a look at hepatic clearance. Drugs are delivered to the liver and they're metabolized there to make them inactive and hence cleared and removed from the body. Some drugs have very high hepatic clearance. So the liver enzymes that are involved avidly metabolize the drugs. So for example, morphine has hepatic clearance of about 1,000 mils per minute. This compares to about 1,500 mils per minute, which is the hepatic blood flow. Other examples are drugs such as nitroglycerin, verapamil, and propranolol, which also have very high hepatic clearance values. Now, the drugs are delivered to the liver when they circulate around the circulation, but with oral administration, they're delivered to the liver on first pass metabolism after they're absorbed through the small intestine. So the hepatic extraction of these drugs, such as morphine, nitroglycerin, verapamil, propranolol, are high. So in their case, their hepatic extraction is defined as the hepatic clearance of the drug over liver blood flow. So in the case of morphine, the hepatic clearance is about 1,000 mils per minute. Liver blood flow is about 1,500 mils per minute. So about 2/3 of all the morphine, which is absorbed through the gut and goes through the liver on hepatic first pass, is actually cleared. And this is important because this impacts on the bioavailability of the drug. So high hepatic extraction drugs have low oral bioavailability. And as we'll hear in the bioavailability lecture, this is not desirable. So renal clearance has 3 important components. So this is a really badly drawn worm, which is meant to look like a nephron. So here we have the glomerulus, and we have then these bits. So the 3 components of renal clearance are the following. So firstly, you get filtration, and the drug that is free in plasma, which is not bound to albumin, filtering across into the urine here. But there's two other components as well. Firstly, you can get active secretion of the drug into the urine. And this might be through transporters and other means. But then you can also get active reabsorption of the drug out of the urine back into plasma. So renal clearance is really quite complicated because it's a combination of these three things. And depending on what the drug is, you might find that in fact these different components make up a small or large part of the overall renal clearance of the drug.